Okay, we'll go ahead and get started. So we've got this back room down in the neuro area there, and there will be these kind of strange electrical sounds emanating from there periodically. I think people wonder what we do back there sometimes. But what we do is electrodiagnostics, and that's what we're going to talk about here today. We've got this snazzy imaging now that Amy loves, and gives us these beautiful images of the brain that tell us absolutely nothing about function. So in addition to structure of the nervous system, we're also interested in function. And our neurologic exam is the first look we have at the function of the nervous system, because we're challenging it and making it do things. But the nervous system works on electrical impulses, and so we can also get a good read on function by using electrodiagnostics to look at the electrical function of the nervous system. So we can kind of think about electrodiagnostics as an extension of our neurologic exam, a way of further probing the nervous system's function to see what's going right or wrong with it. So what we're going to do here today is first look at where these electrical potentials come from that we record, talk a little bit about the equipment, how it's set up, and some of the safety issues, and then talk about peripheral nerve and signal averaging evoked potentials, EEG, and if we have time, talk about where we apply these. So when we were talking about action potentials in the neurophysiology portion of this course, these are always intracellular recordings. So we're sticking electrode actually into the cell or the axon or the muscle, and we're watching the current fluxes that are mediated by the flow of sodium into the cell and the flow of potassium out of the cell. And that's what gives us that characteristic waveform that we recognize as an action potential. Now, when we're recording for electrodiagnostic purposes, we're not doing intracellular recordings. We don't have very fine needles. We're not placing them very precisely within the cytoplasm of whatever it is we're recording from. We're out there in the tissue somewhere at some distance, actually. Now, sometimes not very close, sometimes very close, but never inside the axon or the cell body. So what we're recording is the fluxes in the ions within the extracellular space, those ions that are surrounding the excitable membrane that we're interested in. So when a membrane depolarizes, when a sodium channel opens and sodium comes into the cell, we'll get a negative charge on the surface of the cell in that vicinity, because all of a sudden the positive ions have flowed into the cell, leaving the exterior relatively negative. Now, as we talked about when we were talking about capacitance and all that sort of stuff, there's going to then be a flow of the positive ions from the surrounding area to that negative charge, because everything wants to equilibrate. And so we have initially this sink, it's called, where the ions flow into the cell, leave a negative charge on the outside, and then we're going to have a source of positive ions to replace the ones that were lost and restore the electrical equilibrium. So these extracellular recordings that we do are often referred to as sink source recordings. So we're not actually recording the action potential itself. We're recording the flow of these ions that's happening in response to the changes in conductances that has generated the action potential. And so when we're recording, we've got a electrode out there in the periphery. And actually what we're going to be recording is really called a sink source when we're talking about nerve conductions and EMG, because there's going to be a source on either side of that sink. So ions are going to flow from both in front of the sink and behind the sink into the sink to restore equilibrium. And this is often called a tripole. So you have a leading positive charge, you've got the sink, which is a negative charge, and then you've got the trailing source. And so when we're recording extracellularly, what we're actually seeing is first this area of positive ions that are starting to flow towards the sink. And so we get an initial, and then this is as an action potential is running down this nerve or muscle membrane. So we get an initial positive deflection of the waveform that reflects this leading source. Then when we get actually over the sink itself, the membrane becomes negative. So we then get a negative deflection of the electrical recording. And as that wave of depolarization moves on, the trailing source goes under the electrode, we get another positive deflection, and then it trails off. So in a classic recording of a action potential running by, but an extracellular recording, you get this triphasic kind of wave. Now the waveform will vary depending on where the generator of this action potential is and so on, which makes it a little more complicated. And so often they don't look like a perfect triphasic wave like that. But that's what is actually generating this wave that we're recording. So we're kind of recording the remote effects of that action potential flowing by rather than the action potential itself. Now, when we're recording the electroencephalogram, we're even farther from the action. We're out there in the subcutaneous tissue or even on the skin, very far removed from the action. The cortical neurons tend to be organized in columns with the axons going away from the surface. And so the action potentials are actually going away from our electrode, not underneath it. But we're still going to have this sink source kind of a activity going on there, where as those action potentials flow away, the ions have to move around to kind of restore equilibrium. Only it's not a linear kind of a process. It's more a summation of all these things that are happening in the brain, remote from our recording, and this is called a far field potential. Okay, so the equipment we use, we need some electrodes to detect these things. You can do this with surface electrodes. The crudest is an alligator clip. Silver chloride discs are often used to give you a good contact with the skin. But more often than not, we're sticking needles, at least into the skin, if not into the muscle. These can be just these platinum wires that are just very fine platinum needles that you can stick under the skin. Often we'll use stainless steel electrodes. And for EMGs, our recording electrode is typically coated with Teflon, except for the very tip. So it's a slick Teflon coat that slides through the tissues more easily, less drag, less discomfort for the patient. But we want a relatively small recording surface when we're recording things like the EMG. And another setup that we can use there is to have a concentric electrode where we have just a needle shaft on the outside. But if we look inside the needle where the bore should be in a regular hypodermic needle, that's filled with insulation, and there's a fine wire that the tip of it is at the edge of that. So we have an outside reference electrode, and inside we've got the very small recording surface. So that's another kind of electrode setup that we often use. Now, when we're looking at these things, the electrodes, the impedance of the electrode is an important consideration. So impedance is the resistance to flow of electrical currents. And it's mediated by Ohm's law, which says that the impedance is the voltage divided by the resistance. And we can, with modern equipment, we can measure what the impedance of the electrode is. Basically, the machine puts a voltage across two electrodes and then measures how much current is actually flowing, and that gives us the impedance. And we want a very low impedance. We don't want a lot of resistance to the flow of current because we want to be able to record it. If there's too much resistance, then we can't get a good read of the recording. So usually the first thing we always really should do is check the impedance of our electrodes. And again, the modern equipment does that for us, and we want very low, less than 5 kilo ohm kind of impedance. the impedance is high, either we haven't placed the electrode very well, we don't have it, in the skin well. The electrode might be bad, you get breaks in the wires, you get, oxidation of the coating and stuff. Or sometimes it can be a problem with the equipment itself. This is one of the things we need to troubleshoot. If one of these electrodes come up with an impedance of 25, then we've got to mess around with it and figure out what's wrong and get it down to where it's going to give us a good recording. So the EMG is kind of one of the simplest electrodiagnostics that we do, where we stick an electrode into the muscle. We have an amplifier, actually it's a pre-amplifier and an amplifier typically in these things, although nowadays they're often built into the same unit. And then that electrical impulse is amplified. It's displayed on a screen. Used to be an oscilloscope, now it's all computer-based. And there's a audio that we listen to. The reason we listen to the audio is that these are transient waveforms flashing by, and we're trying to analyze these waves as they're flashing by. Our eye is not designed to do that, but sound is a transient waveform flashing by. And so our ear is programmed to detect and deal with that sort of thing. When I was doing my PhD work, I was recording extracellularly from dopamine cells in the ventral tegmental area in the brainstem of rats. And you would have to lower an electrode down into the brain of this anesthetized rat. And the brain was, kind of plastic. As you would lower the electrode down, it would push the brain down to some extent too. And if you just kept going until I was right next to one of these dopamine neurons, when the brain kind of rebounded a little bit when I stopped, I would end up poking the neuron and it would die. So I'd have to listen for the neuron. They would make this characteristic popping sound. And I could hear that neuron popping out there long before I could see anything in the wave. You just get this little faint pop, 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 pop in the background. And as soon as I heard that, I knew I was getting close, and I would have to stop, advancing my electrode anymore. And then gradually, as the brain kind of, pushed back against the electrode and then, moved back down a little bit more, the neuron would come into, to visualization, and I could record from it. So your ear is much better at picking up these kind of things than your eye is. And so that's why we always listen to the electrodiagnostic recordings, and you're going to hear some of them here. And the sound, they talk a lot about what they sound like. Now, another big concern is patient safety. They've now redesigned these plugs so that you cannot plug them into an outlet. But believe it or not, somebody took electrodes from an EEG and plugged it into the wall socket and electrocuted the patient. And so now they had to put these, don't plug these things into the wall on the electrodes, and they've changed them now so that you can't even physically do that. The bigger concern about patient safety is grounding, okay? You have to have a good ground, a solid ground, both to get rid of noise and also just for patient safety. Because the idea is sometimes there'll be leakage currents. Sometimes in electrical equipment you get shorts, you can have, conduct capacitance currents that get generated. And if there is a charge generated within the equipment somewhere, somehow, you want to make sure that the only place that charge can possibly go is into the ground and not into the patient. So you want all the equipment, if you're using multiple equipments, and again, with modern stuff, it's all one big package and you don't have to worry about this. But when we used to have separate, stimulators and separate preamps and separate recording amps, you had to make sure that all of the grounds, there was one common ground for all that equipment. And that the patient is actually grounded to the same ground as the equipment. Because what you don't want to happen is to have the patient have an independent ground. So if we stuck a needle into the patient, for example, and then clapped the alligator clip to the pipe or something like that for a ground, if you got any stray current generated within the amplifier, that current's going to want to flow to the ground, and the way it's going to flow to the ground is going to be through the patient. and that's where we, shock the patient, and that could potentially be very dangerous. So, again, with the modern equipment, it's not that big a deal, but you want to make sure that there's only one ground. The patient is grounded to the equipment, all the equipment is grounded to the ground, and, because what we're trying to avoid is that classic, dryer in the bathroom kind of scenario where there's a short in the dryer. She's touching the dryer, touching the pipe that's got a ground, and the current's going to flow through her, and that's not healthy. We also try to avoid extension cords because you can get capacitive currents when you've got currents flowing through wires. They can sometimes influence adjacent wires, and you can get some current generated in the ground wire that way. And so, sometimes you have to use an extension cord, but you need to be aware that, particularly if you have a really long extension cord, you can generate some currents in your ground, which you don't want. Both that interferes with the recording, and it can be potentially a hazard. Okay, so we've got the patient wired up safely. Now we're going to start amplifying things, and we have to look at what the settings are on our amplifier. The first consideration is, what is the polarity? Which way is up? It seems intuitive enough. Up should be up, but for whatever reason, when they started recording EMGs, they set it up so that positive was a downward deflection. So these are called positive sharp waves, even though the wave is going negatively. So it's just kind of bass-backwards. Most other electrodiagnostics do it right, and they have positive as an upward, kind of deflection, but the EMG, it's different. So you just need to be aware which way is the positive current. The x-axis is the gain, the amplitude of the impulse, and we can adjust the gain by changing how much amplification is there. We want to be able to see the recording that the waveform that we're looking for, but we don't want it truncated like it is here. We don't want to be chopping off some of the waves because we've got the gain turned up too much. Turn up the gain, we get more noise. So we adjust the gain to get the waves that we want without clipping them or having too much noise in the background. The y-axis used to be called the paper speed when we were recording these on paper. Now they call it the sweep. That's how, what the time scale is. And you adjust the time scale to be able to see the waves that you want. If we shrunk this time scale down too much, the up and down stroke would come together. It would just look like a line. So we try to adjust the sweep, again, to be able to see the waveform that we want accurately and get all the information we can from it. And last, there's the filters, bandwidth. So we filter the frequencies, so there's all kinds of frequencies in this recording that we're doing. And we're going to want to filter it down just to the frequencies that we're interested in. So, and here again, there's some kind of confusing terminology because, there's a high frequency filter that'll filter out, that will cut out high frequencies, but sometimes this gets referred to as a low pass filter. So usually nowadays, most people call them high frequency filters or high cut, because it was confusing when you called it the low pass, because, which one are you talking about? Okay, so here's an EEG. We'll talk more about that probably Wednesday. Lots of noise in this recording. Right now, our sensitivity, our gain is set at 7 microvolts per millimeter, and these are our high and low frequency filters. So our high frequency filter is set at 70 hertz. There's lots of noise in this recording. There's lots of EMG contaminating the EEG that we don't want. And so we can get rid of some of that by cutting down on the high frequency filter. So when we cut the high frequency filter down to 15 hertz, you see we've got rid of a lot of this noise in the bass line. This really bad interference here we didn't get rid of. We still got that. But we've got a much cleaner bass line. We've gotten rid of all that high frequency noise that was obscuring our signal. So that's good. But there's also a downside to filtering. So here are some epileptic spikes in a dog at the standard kind of EEG filter settings of 70 hertz and half hertz. And you can see these very nice spikes. If we crank the high frequency filter down to 15 hertz like we did before to get rid of noise or whatever, look at what happens to these spikes. We've actually filtered out about, I don't know what, 20% of that spike. So our amplitude has changed. It's the same recording, I mean, this was, saved. I'm just playing with the frequency filters here. And so you lose data when you filter. And so it's always a balance between filtering the signal to get rid of enough noise so that you can see the signal that you want without filtering out data that you need. And so we can still see these spikes, so that's okay, but we would misjudge the amplitude of them if the amplitude was important, if we cut back on the high frequency filter like that, because we cut out the high frequency component, the really sharp spike of that particular spike. Now then there's the low frequency filter, the low cut or the high pass filter. So what high frequencies are we allowing to pass? If you look at this recording again, we got a lot of baseline shifts. This dog was moving around a little bit. This is a big movement artifact here where it goes off the screen. We lose all the signal. Sometimes you get these DC shifts in the baseline where just the basal charge of the animal in general changes a little bit and the baseline goes up and down. So we can get rid of those by cranking up the low frequency filter. So here we're at a half a hertz. We crank the low frequency filter up to 10 hertz. We get rid of all this baseline noise. We still have a little bit of a movement artifact over there on the end, but it's not so bad. And we've got a much more stable baseline, and the recording looks a whole lot better. Trouble is, some of the waveforms we're looking for on an EEG are 3 hertz kind of frequencies. So if we crank the low frequency filter up to 10 hertz, we've obliterated, and this is kind of a 3 hertz signal here. So these solid lines are 1 second. So this is kind of a 3 hertz wave there. That may be a significant physiologic wave, and yet we've filtered it out with our low frequency filter. So there's always this balancing act between cleaning up your signal, getting a pretty looking signal, and getting rid of the noise that might obscure your information. And on the other hand, if you filter too much, then you filter out the information you're looking for. So there's always a balancing act there. Now the other filter that we use frequently is a selective 60 hertz filter called a notch filter. So if we're getting 60 hertz interference from the fluorescent lights or something like that, we can turn this on and very selectively filter out the 60 hertz noise. Okay, so with that background, let's talk about electromyography. Like I said, this is the simplest. We're recording a near field potential. I forgot to define that term, but when we're doing these extracellular recordings close to the generator, that's called a near field recording. With the EMG, we're only recording the spontaneous activity that's happening in the muscle. So we're looking at what the muscle is doing, on its own. So the other thing I didn't talk about when I was talking about these recordings and electrodes is that we always do a differential recording. So we have a reference electrode somewhere on the body. In the case of EMG, we try to put it over a bony prominence, a place where there's not going to be a lot of electrical activity going on. Then we've got the recording electrode in the muscle. And what we're actually amplifying is the difference between those two electrodes. So you can do this other ways. You can do a non-reference recording. But what this does is it gets rid of a lot of the noise. Because, like, for example, 60 hertz interference from fluorescent lights in the room, that would tend to be hitting both of these electrodes at the same time. The EKG, which is a 2.5 millivolt signal, and we're often looking for 10 microvolt signals, is going to obliterate everything. But the EKG signal is going to be coming from far enough away that it hits both of these electrodes at the same time. And so this gets rid of a lot of the interference. It gets rid of a lot of the noise and artifact by doing this differential kind of recording. And then we have one of those concentric electrodes. The outside is the reference, and that thin, tiny electrode surface at the point of the needle is our recording surface. Okay, so when we're recording an EMG, one thing we're interested in is motor units. One neuron in a muscle like the leg is going to branch and innervate hundreds of individual muscle fibers. You know, extraocular muscles are 1-to-1, but most muscles, you know, you've got this, you know, multiple nerve fibers innervated. So we can actually record a motor unit action potential when one neuron fires. That neuron's going to depolarize all of these individual muscle fibers in the motor unit synchronously. The conduction time is down the little branches is timed so that all the fibers fire as a unit. And we get this, you know, usually triphasic kind of wave that's generated by this contraction of the muscles fired by a single motor unit. And there are normals, you know, identified for this. And in people, they can actually quantify, you know, motor unit, you know, amplitude, duration, that sort of thing pretty easily. They do an EMG on you and say, just relax, okay, try to contract that, try to pull your finger up ever so slightly, and you'll start to see these motor units. Now, when we try doing this in a dog, this is what we get. This is called an interference pattern, where the dog is trying to jump off the table because we just stuck a needle into it and all the muscle fibers are firing at once. And so we can't tell anything about an individual motor unit when they're all firing at once like this. Now, in people, they can actually quantify this sort of thing too. They can quantify just how much noise is generated in an interference pattern. But there you have to do a maximal contraction. So they'll say, okay, pull, you know, squeeze my hand as tight as you can, and they'll see just how much noise is generated. Well, we can't do that either because we can't get the dog to, you know, we know he's struggling and so on. So we can't quantify these things very well. We can't look at the individual motor units or this summation of motor unit activity. In fact, we want to get rid of it, and so we usually have to either heavily sedate or anesthetize the animal to get rid of all this noise, because the dogs don't like us sticking needles in them, and they'll jump, and we get, you know, so much noise we can't filter out and can't see the signal we're interested in. So we put them under anesthesia, and we'll stick a needle into the muscle. As we stick that needle into the muscle, the physical act of the needle penetrating the muscle, going through nerve fibers, tearing nerve fibers, generates firing of those fibers as they're being torn. And so we get this brief burst of activity that's called insertional activity. Boop. That's all it is, just this of activity. That's the physical action of that needle. And it's normally a very brief burst, and as soon as you stop moving the needle, it stops. Okay? Now, when a muscle is denervated, the muscle fibers start to change. And it's a little bit paradoxical that when the muscle gets denervated, it starts to become more active. But the nerve has a trophic influence on the muscle. It influences the muscle. And when we lose that trophic influence of the nerve on the muscle membrane becomes unstable. It is no longer in a nice, even resting membrane potential. The ion channels start to move around, and everything kind of gets out of sync. And so what we're going to see when we have denervation is the first thing we see is that because those fibers are kind of irritable, the irritation that needle creates is more dramatic, and we get a prolonged insertional activity. So it doesn't stop as soon as I stop. It keeps going. Okay? So the earliest change that we'll see in denervation, and another important take-home message, is that this takes time. If I cut a nerve and stick a needle into the innervated muscle today, I'm not going to see anything because that muscle fiber hasn't had time yet to undergo these changes from the loss of the trophic influence and become hyperexcitable like that. So it takes 5 to 14 days for any changes to occur in the muscle, which is always a problem when you're dealing with an acute injury and you'd like to get a feel for what the nerve's doing right now, but you can't with this technique. Now, when if a motor unit is killed and those muscle fibers are denervated, after a week or so, they will start firing spontaneously. So they will start generating action potentials even when I haven't jabbed them with a needle or done anything to them. Now these are individual muscle fibers firing, so if you look at the muscle through the skin, you can't see this, you can't visualize this. So it's not like a fasciculation or a tremor or anything like that that you can see. But these individual muscle fibers are in there firing randomly and spontaneously, and we can record that with our EMG. And they look like the motor unit action potentials, biphasic, triphasic kind of waves, but they're very tiny, because rather than having hundreds of these all firing at once, we've got each one firing individually. So they're much smaller amplitude, shorter duration than a motor unit action potential. And they'll vary a lot in the configuration. Sometimes they'll be biphasic or triphasic, or they can even be monophasic. And these are said to sound like eggs on a tin roof. And this one isn't as good. But you can see them there. Let me stop this one. And thought I had another one. Oh, there it is. Oops. There we go. So it sounds like a thunderclap when you get that insertional activity. And then the insertional activity starts to calm down. You're not moving the needle anymore. You still have these little firings in the background. So these little crackly sounds, and again, the fried eggs or rain on a tin roof is how people describe it. These little cracks, they're very random, irregular in their patterning, and they will, quiet down after you get done moving the needle. But they're always there. They're just kind of continuous because these fibers are not happy and they're letting the world know about it. Now another waveform that we'll see with denervation is the positive sharp wave. These are much larger. They're a big wave, about the same amplitude as the motor unit action potential. But they just have a single positive deflection and then a overshoot past the baseline and then another one. These are sometimes called injury potentials, and I'm not going to get into the physics of it here, but basically what happens is that sink source wave that's coming down the axon hits a roadblock and just kind of stops and doesn't propagate anymore. So you see the positive, leading source, but then once it gets there, the action potential doesn't propagate past the electrode. And so you don't get you get a little bit of a negative, deflection, but it's a very different looking waveform. This is often the first change that we'll see in terms of spontaneous activity in the muscle. Prolonged insertional activity is typically the first thing, but then the spontaneous activity that's not in response to the insertion can be these positive sharp waves. Often they'll occur in runs. Following the insertion. They sound different. They've got more of a popping sound to them rather than that cracking sound. And they're very easy to pick out on the screen because it's just this single downward deflection. So that's the kind of thing that we see in denervated muscles. These muscle fibers fire spontaneously because they've lost their nerve, and when they don't have their nerve to tell them what to do, they start just screaming at the world because their membrane is unstable. Yeah, another form of spontaneous activity that we can see is myotonia. And myotonia is a failure of the muscle membrane to relax. And we'll talk more about why this happens with chloride channels and stuff, I guess, in the muscle disease section. But when you get a contraction of the muscle, it can't relax because the chloride-mediated, repolarization of the muscle membrane isn't functioning like it should. And so these are usually primary muscle membrane disease kind of discharges. And they sound like a dirt bike or a dive bomber. Dive bombers are the typical way that they're described. although Kimura, who wrote the Gospel on electrodiagnostics, says, he's an older guy now, but he in his book he says, I have lots of experiences with dive bombers, and these don't sound like dive bombers. Apparently he was in World War II in Japan. So he doesn't think they're dive bombers, but that's what everybody thinks. So they have this musical kind of quality to them that waxes and wanes, and that's where the dive bomber kind of sound comes from. But notice there's an abrupt end there to one of the sounds, and listen here. Boom! It shuts off very suddenly. And that's one of the other things that we listen for when we're recording these, is what is the offset like? So our needle probably gets these things going. It's probably a very prolonged insertional activity, because these will go on for 30 seconds, a minute or so. And you get these kind of polyphasic waves. Some of them can be very rhythmic and have a very musical sound to them. Some of them can be more harsh, and they do sound more like a dirt bike kind of bing-a-ding-ding kind of sounding. But they're very repetitive. Sometimes the waveform changes, and that gives you that variation in the sound, because you have multiple ones there. And sometimes one of them will cut off as one fiber stops firing, and then you get the sound changes. Other times they can be very rhythmic and very consistent and a very buzzy kind of sound. One of the big distinguishing features that we look for is whether there's that abrupt offset of the sound, or whether it just kind of waxes and wanes and slowly trails away. And the terminology here gets confusing, and then tell you the truth, I really should have gone and reviewed it, because I don't know what the current correct terminology is. But the point is that you're looking for whether it's got this waxing and waning kind of character, or whether it has this very abrupt offset where it just boom, stops very suddenly. Okay, another kind of spontaneous discharge that we can see is myokymia. Myo means muscle, and chyma means wave. So these are waves of contractions within the muscles. So we can see these. We can see myotonia too. The animal's just stiff. But you can see these contractions that seem to flow through the muscle. So it's a repeated contraction of the muscle, but it's not a sustained contraction like the myotonia, where the muscle is just stiff, but rather these wave-like contractions. So these are originating from the motor unit. It's a hyperexcitability of the neuron itself. And so this isn't a problem with the muscle membrane like denervation or myotonia. This is originating from the nerve, and the nerve is the axons of a neuron, a lower motor neuron, are firing repeatedly, often in pairs or triplets. And so we can see this in the EMG. So you got usually 2, 3, 4, 5, 6 motor units all firing synchronously. And the way they describe the sound is soldiers marching, because they have this fairly repeatable firing of groups of neurons. So it's kind of this kind of sound. And these are usually problems with the ion channels, either in the axon. You can have autoimmune diseases that are affecting ion channels in the axon. Or it can be arising centrally, where you've got like a potassium channel that's not buffering potassium like it should up there, and the motor neurons become hyperexcitable, and you get groups of them then firing together. So you get groups of motor units firing together, and this kind of a EMG picture. Now, one of the other type of EMGs that gets done a lot in human medicine, but we don't do it too much in veterinary medicine because it's technically difficult. Again, it works best if you can do a voluntary contraction sort of thing, is a single fiber EMG. And what's different about a single fiber EMG is that the recording electrode is very, 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 very tiny. So it's a concentric electrode where you've got the reference around the outside, and then they have actually typically a series of these tiny fibers on the surface, and you can select which ones you want to record from. So the idea here is to try and restrict our recording to a very small volume of the muscle. What we're trying to do with single fiber EMG is find two fibers that belong to the same motor unit, so that when one fiber fires, the other one always fires, because they're branches of a single axon that are innervating two fibers. And again, you've got to get voluntary, you've got to get contractions, you've got to get motor units firing. So this is difficult to do for us because we usually have to have the patient asleep. So the idea is, again, to find a pair of fibers that we can record from that belong to the same motor unit. Now, if the motor unit is working like it should, these fibers should be firing very synchronously. And so you key off of one of the fibers, that triggers the recording, and the other fiber will fire at exactly the same difference. It fires at a slightly different time because things aren't that precise. But it's always going to fire in sync. So they always fire in this boom, 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 boom kind of pattern, unless there's disease. If there's disease, then you can get the situation where those two components of the motor unit aren't firing at the same time like they should. And so again, you trigger off of one of the fibers, so you got some way of triggering the recording, and look at what happens to the second fiber. If the second fiber isn't firing in sync, then that's called jitter. So there's some variability in when that second fiber fires relative to the first one. The other thing that can happen is we can get blocking, where one fiber fires but the other one doesn't. And you can see the jitter, that it's firing at different times, but periodically it doesn't fire. It just doesn't get up the threshold and can't do it. This is a hallmark of myasthenia gravis at its very early stages, where you have one neuromuscular junction that can't fire an action potential when the other one can. Sometimes this can happen with distal demyelinating diseases, but we don't do it very often in veterinary medicine, just because it's tough to get a good recording of that, because we can't get the animal to just do a minimal contraction of his extensor digitalis brevis. Okay, so with that, now we're going to start doing something. So everything we've been doing so far is just sticking a needle in there and listening to what the muscle is doing on its own. But we can externally stimulate and record a response, externally stimulate the peripheral nerve by running a current between two electrodes that we've placed next to the nerve. And then we can record a response from the muscle that is innervated by that nerve. Now, when we start putting current into the dog, we've again got to think about patient safety. Because if you run 100 milliamps of current through the heart, you could induce ventricular fibrillation and you could kill your patient. And the ground is not going to protect against that, because we're not talking about a stray current coming from the equipment. We're talking about current that we're deliberately putting into the dog, and usually the ground is out there on the foot or somewhere else. So if we have two electrodes that are on the patient and the heart is in between them, we could kill the patient by running 100 milliamps through there, probably even less with some of our tiny patients. So the key is to keep the electrodes, your stimulating electrodes, close together and away from the heart. Now this sounds simple enough, but when we're doing these EMG recordings, sometimes we've got a half a dozen electrodes stuck in the dog, and you get confused about which is your stimulating electrode and which is your recording electrode. You go to move a recording electrode and you accidentally move the stimulating electrode to the other leg or somewhere else, and you end up with them separated, the heart in between, and that's where you could get into trouble. So we've got to be very anal about knowing where are our stimulating electrodes when we're doing this. Now, another thing we have to keep in mind when looking at this is a process called anodal block. Now, the way to remember a cathode versus anode is black cats are negative. So the cathode, the cat, is the black lead, and it's the negative electrode. Okay, so you just have, it's just a little mnemonic how you learn to keep it straight. The reason that's important is when you put current through a system like this, the current is going to flow from the anode to the cathode. And the depolarization of the membrane occurs under the cathode. Now, normally an action potential is only going to go one direction because it was generated from a synapse up in the cell body there. But when we stimulate in the middle here, we're going to depolarize that membrane. There's no refractory period, because there's nothing that happened before we stimulate. So we generate action potentials going both directions from that cathode. Now, when we're depolarizing under the cathode, we're actually hyperpolarizing the membrane under the anode because the current has flowed away from that area. And so what can happen is the action potential that's going towards the anode can hit that area of hyperpolarization and short out and not get conducted. This doesn't happen in a normal nerve or a normal muscle, but it can happen in diseased nerve. And so when we're setting up our stimulation, we always want the cathode on the side where we want the action potential to go. So if we want the action potential to go that way, we put the cathode on this side and the anode on the other side, so that we don't have to worry about this anodal block as a potential complicating factor. Now, when we stimulate a nerve, if you went in to get a nerve conduction velocity, the doctor would just say, this is going to sting a little bit, and you'd have to kind of gut it out because you're stimulating the sensory fibers as well. And so you get a pain afferent, shooting up towards your brain when you stimulate this. So we always do this under anesthesia. There are, again, controls that we have to, look at. What we're interested in is how many milliamps of current it takes to depolarize that neuron. The current, again, going back to Ohm's law, is voltage divided by resistance. The control that we have on the machine controls the voltage of current. But the modern machines actually measure the current, which is what we're interested in. So they're actually measuring how many milliamps of current is flowing when we do the stimulation. We're interested in the duration of the stimulus, how long do we stimulate, as well as how many milliamps we're putting in there, and how frequently we stimulate. And we'll talk more about that here in a minute. Now, there are two measures that are sometimes done. This is really more old school. You don't see this too much anymore. But you can measure how excitable is that axon by looking at how much stimulus does it take to get it to fire. So one measure of this is what's called the Rio base, the base of the rheostat. And you basically just put a constant voltage in there and gradually turn up the intensity of that voltage, so that it's infinite duration, but what's the intensity of the voltage that actually produces then a firing of the nerve. The other measure that can be done is chronaxy, where you take 2 times the minimum intensity that it took to fire that nerve, and what's the minimum duration of the stimulus that gets the nerve to fire. And a sick nerve is harder to fire than a normal nerve, and so they used to sometimes measure these. The more important thing now is just recognizing that if the nerve is sick, then you have to worry about anodal block, and sometimes it's hard to get it to fire. And if you have to crank up the amperage to 37 milliamps to get a nerve to fire, something's wrong with that nerve, or with your placement of your electrode, because it should fire at a much lower current. Okay, so we can stimulate the nerve. If I'm trying to record from a muscle down here, I'm going to want to have the cathode distal, so that anodal block, if it happens, will block the stuff going up to the spinal cord. We insert the recording needle into a muscle innervated. The reference by convention goes at the tendon of insertion, but you just need a quiet place. And usually we put the ground in between so that any stimulus artifact gets bled off from the ground. And when we do that, we can record what's called a compound motor unit action potential, or an M wave. We're stimulating the entire nerve for the most part, and so we're firing every motor unit in that nerve And so we get a compound motor unit action potential. It looks just like that single motor unit action potential, only it's a whole lot bigger because we've now got a whole bunch of them, and it's a little longer duration and so on. And so we can then look at that and see how well is that nerve communicating with the muscle. If we've lost axons, if we have conduction block in that nerve, then we'll see a shrinkage of the amplitude. That other, that normal one you saw before was about 6 millivolts. This one's shrunk down to 2.5 millivolts in amplitude. We can also see, that the waves often become funky. Rather than being nice, clean, triphasic waves, they become polyphasic, and we'll talk more about that in a minute, and it's called temporal dispersion. Or we may not be able to evoke a compound motor unit potential at all. We may stimulate the nerve and nothing happens. When that happens, the first thing we do is start checking our equipment, make sure that we don't have something messed up, that a wire isn't broken, that we, But if we got everything right and we can stimulate another nerve and get a response, we go back to this nerve and don't get any response, then that tells us that that nerve is not functioning. Okay. All right, so let's quit there for today, and then we'll pick this up again on Wednesday and finish talking